In this lecture, we're going to be talking about the characteristics of the subsolid pulmonary nodules, the new proposed classification for the lung adenocarcinomas by the International Association for the Study of Lung Cancer, the American Thoracic Society, and the European Respiratory Society. We're going to go over the differential diagnosis and the prognosis of the subsolid nodules and the proposed guidelines for management of these lesions. So as you know, on CT, pulmonary nodules, they can be solid or they can be subsolid. And the subsolid nodules are divided into ground glass nodules, like this example, and part solid nodules, that are the ones that have a solid component and also a ground glass component. It's very important that for evaluation of these lesions, we need to use thin section images so that we can assess for the presence of a solid component within these lesions and also the percentage of solid versus ground glass component within these nodules. And that's because this carries important implications for the management and also prognosis of these patients. Our awareness of the importance of the subsolid nodules and its relationship with the spectrum of pulmonary adenocarcinomas has increased with the lung cancer screening studies. In a study by the LCAP, for example, from the detected lesions, 34% of the detected subsolid nodules were malignant versus only 7% of the solid nodules. And within the subsolid nodules, 63% of the part solid nodules were malignant and 18% of the ground glass nodules. Then later on, close correlation was described between the CT features and the histologic classification of the adenocarcinomas. This table shows the relationship between the WHO 2004 classification of adenocarcinoma that we have been using and the new classification by the International Association for the Study of Lung Cancer, American Thoracic Society, and European Respiratory Society, and correlation with the CT features. So atypical adenomatous hyperplasia has not changed in the nomenclature and usually presents as a small ground glass nodule, usually less than 5 millimeters. The term bronchiolialveolar cell carcinoma has been replaced by adenocarcinoma in situ. And this on CT tends to present as a pure ground glass nodule, but it might have a solid component because of structural collapse within the lesion. The adenocarcinoma mixed subtype with BAC component has been subdivided into three categories. First one is minimally invasive adenocarcinoma. This is a new group that was created because there are studies showing that when you have a tumor that is predominantly lipidic but has a small area of stromal invasion measuring up to 5 millimeters, the prognosis of these lesions is still excellent, very close to the adenocarcinoma in situ, with near 100% 5-year survival rate. So because of that, they created a new group, the minimally invasive adenocarcinoma. And on CT, this may present as pure ground glass nodule or may have a small solid component. The next group is lipidic predominant adenocarcinoma, and this corresponds to the adenocarcinoma mixed subtype with non-mucinous BAC component that have invasive component more than 5 millimeters. On CT, they tend to present as part solid nodules or solid nodules. However, in up to 7% of the cases, they might present as pure ground glass nodule, simulating an adenocarcinoma in situ. So there is overlap between these groups. The next is invasive mucinous adenocarcinoma, and this is the adenocarcinoma mixed subtype with mucinous BAC component. On CT, they tend to present as a solid nodule or predominantly solid, part solid nodule. They might also present as consolidation. The other types of invasive adenocarcinoma are now termed based on the predominant type. So, for example, SNR predominant adenocarcinoma, papillary predominant adenocarcinoma. And these lesions, they tend to present as solid nodules or predominantly solid nodules. So, as you can see, as we go from lesions that are less invasive to more invasive and more aggressive, on CT we increase attenuation of these nodules from pure ground glass nodules to part solid nodules and then solid lesions. And the prognosis of these patients decrease. Let's go over this new classification. Atypical adenomatous hyperplasia is a precursor of adenocarcinoma. On histology, we can see mild to moderate atypical cells along the alveolar septum, and there is no thickening of the alveolar walls. And on CT, small ground glass nodules, usually up to 5 millimeters. Adenocarcinoma in situ is therefore the new term for previous bronchioalveolar cell carcinoma. These are pre-invasive lesions. They have pure lipidic growth, so no stromal invasion. Also no vascular, lymphatic, or pleural invasion. Because of that, to make the diagnosis of adenocarcinoma in situ, we need the complete sampling of the lesion so that we can make sure there is no stromal invasion. And this is one of the limitations of using transthoracic biopsy for these lesions. The vast majority of the adenocarcinoma in situ are non-mucinous because the mucinous type are more aggressive and usually more advanced. Here's an example of an adenocarcinoma in situ, non-mucinous, and we can see a single layer of atypical cells along the alveolar wall. This tumor does not cause destruction of the pulmonary parenchyma, and this is the lipidic pattern. And also there is no stromal invasion. On CT, we can see pure ground glass nodule. Minimally invasive adenocarcinoma. These lesions are predominantly lipidic, but they have a small area of stromal invasion, here characterized by fibroblastic proliferation. They don't have lymphatic, vascular, or pleural invasion. And again, we need complete sampling so that we can make sure that the area of stromal invasion is up to 5 millimeters. And on CT, the area that we see as a ground glass corresponds to the area of lipidic pattern, and the small solid area corresponds to the area of stromal invasion. Lipidic predominant adenocarcinoma is the adenocarcinoma mix-up type with non-mucinous BAC pattern on prior nomenclature. So we can see there is a predominant area with lipidic pattern, but one area of stromal invasion that measures more than 5 millimeters. And these tumors may have lymphatic, vascular, or pleural invasion. On CT, they tend to be part solid nodules, but they can be solid and rarely ground glass in attenuation. Invasive mucinous adenocarcinoma is the former adenocarcinoma mix-up type with mucinous BAC component. These lesions also have a lipidic pattern, but the atypical cells are with abundant intracytoplasmatic mucin, as you can see here. And on CT, they tend to be solid or predominantly solid and also may present as an area of consolidation. Besides the spectrum of lung adenocarcinoma, subsolid nodules may also be benign. They may represent infection, focal fibrosis or scarring, focal inflammations such as focal organizing pneumonia, eosinophilic pneumonia, or focal non-specific interstitial pneumonia. In fact, 30 to 70% of these subsolid nodules will resolve in a short-term follow-up, implying benign etiology. However, the lesions that persist have a high likelihood of being malignant. And however, up to 20% of these will still prove to be benign. And unfortunately, there are no definitive features on CT that we can use to differentiate between these persistent benign lesions and the malignant ground glass nodules. This patient with laryngeal cancer had a left upper lobe ground glass nodule. We can see some reticulation. And then on a 3-month follow-up, we can see resolution of the lesion. Therefore, it was inflammatory or infectious, possibly aspiration. In patients that have known extrapulmonary cancer, the persistent ground glass nodules have a high likelihood of being malignant, but they are usually primary lung cancers and not metastatic disease. This lady with ovarian cancer had a right upper lobe ground glass nodule that was biopsied, and biopsy showed organizing pneumonia. On a 6-month follow-up, we can see development of a solid component within this lesion, raising concern for malignancy. On another 6-month follow-up, we can see increase of the solid component. The lesion was rebiopsied and showed pulmonary adenocarcinoma. Although some of these malignant ground glass nodules will remain stable, others will progress, and we don't know how to predict which ones are going to progress or when they are going to progress. In a study by Takashima and colleagues, for example, from the malignant lesions that presented initially as pure ground glass nodules, 75% of them increased. And then from those, 17% presented a solid component, and from those, 23% presented increase of the solid component, showing that there is stepwise progression of these lesions in a subset of these patients. Let me show you some cases. Ground glass nodule in the right upper lobe. 3 years later, we can see slow increase in size of this lesion. Resection showed adenocarcinoma in situ. Another case, very faint pseudogranulous nodule in the left lower lobe that was increasing in size and density very slowly over the yearly follow-ups, and at time of resection it was lipidic predominant adenocarcinoma, so an invasive tumor. Another case, pure granulous nodule in the right upper lobe, 9 months later increased in size, and then about 2 years later we can see some solid component, and this was invasive mucinous adenocarcinoma. So as you can see from these cases, these tumors tend to progress slowly, and the volume doubling time is much greater compared to the solid nodules, especially for the granulous lesions. And one implication that we take from this is that stability over 2 years for the subsolid nodules does not indicate benign etiology, as with the solid lesions. We have to follow these lesions for much more time, 3 to 5 years. Nobody really knows for how long should we be following these lesions. In terms of prognosis, the greater the percentage of granulase within these lesions, the better the prognosis. And that's because the granulase correlates to the area of lipidic growth. There are studies showing that pure granulose nodules and part solid nodules that have more than 50% granulose component tend to have no nodal metastasis or post-operative recurrence. And this has led to an increased interest in performing limited resection of these lesions, such as wedge resection or segmentectomy, as opposed to the lobectomy, which is still the standard of care. This is very important, especially for patients with more than one lesions, and that may require later on further resections. I'm going to show some proposed interim guidelines for management of these lesions, pending more definitive published recommendations that we expect to have soon. So one important fact is that for the subsolid nodules, we do not divide the patients into high and low risk. And that's because the adenocarcinoma has a higher incidence in younger patients and non-smokers. And it's very important to emphasize that these guidelines have to be used in a case-by-case basis in the light of each individual clinical history. So pure granulose nodules measuring less than 5 millimeters do not need follow-up if the patient is enrolled in the lung cancer screening program, or if there are several lesions, then a year low-dose CT follow-up should be appropriate. For larger lesions measuring 5 millimeters or more, then a short-term follow-up can be performed because some of these lesions are going to be inflammatory and may resolve. For the lesions that remain stable, long-term follow-up is advised, 3 to 5 years at least, with low-dose CT. And then if these lesions increase in size or density or develop a solid component, resection should be considered. Part solid nodules, again, a short-term follow-up because they might be inflammatory and can resolve. If they persist, these lesions have a high likelihood of being malignant, and surgical resection should be considered. In this case, a PET-CT may have value in staging these patients. Patients with multiple subsolid nodules, again, a short-term follow-up, these lesions may resolve. If they persist, we have to continue following them with a low-dose CT for a long term. And surgical resection should be considered for the dominant lesions, which are the part solid lesions or the granulose lesions measuring more than 10 millimeters, especially if they increase in size or develop solid component. So in conclusion, the persistent subsolid nodules, they have a higher malignancy rate compared to the solid lesions, and they tend to represent the spectrum of pulmonary adenocarcinoma from pre-invasive to invasive lesions. They might also represent benign etiology, and the persistent granulose nodules, we don't have any CT feature that can definitely differentiate between benign and malignant lesions. Because the subsolid nodules have a greater volume doubling time, stability over 2 years does not indicate benign etiology. And subsolid nodules need to be followed with dedicated guidelines that are different from the ones with the solid nodules, and they must be interpreted in the light of each individual case.